Okay, everyone, we're going to go ahead and get started here. And thanks again to everyone who's joining us today for our webinar on transitioning your clinical lab or pathology practice for post-COVID success. Just wanted to quickly introduce our speakers. My name is Alex Mitchell, and I'm a communications manager with the Lighthouse team. I'll be serving as your host today. We're very happy to be welcoming Robert Michel. His camera isn't on. We're having a few technical issues there, but he's joining us by phone and will be on the audio for this call. Robert is the editor-in-chief and publisher of the Dark Report. From its inception in 1995, the Dark Report quickly became a go-to source of industry knowledge for labs in providing lab management and strategic market analysis. Prior to founding the Dark Intelligent Group, Robert has served in several executive positions for the Nichols Institute, based in Portland, Oregon, and San Juan, California. Well, the Nichols Institute was an independent lab company. He traveled extensively to many of the clinical lab business units owned by the Nichols Institute in different regions of the United States and played a role in formulating the effective market strategies in response to the emergence of closed panel HMOs, capitated pricing, and full risk managed care contracts, among other successful management initiatives. Robert's team also hosts the Executive War College event that we'll be talking a little bit more about throughout this webinar. So we're very happy to have him on with us today. Joining Robert on the panel today will be John Harrell, the president of Lighthouse Lab Services. John has more than 19 years of experience in the clinical lab industry, and he spends each day advocating for the value of clinical labs while also seeking new and more efficient ways for Lighthouse's medical lab clients to bring value to the healthcare ecosystem. And finally, we're welcoming Mick Raich. Mick is the president of the RCM Consulting Division with Lighthouse Lab Services and is the founder of Valuebased Pathology. He's a naturally recognized consultant in the business of pathology and lab billing. His easy style and get-it-done personality have allowed him to become an industry leader. And he's spent his decades-long career in healthcare, including experience with direct patient care, hospital management, and pathology billing. So, gentlemen, thank you for joining our panel today. We're really glad to have you all on.
Thanks, Alex. Glad to be here.
And then just quickly, before we get started here today, I wanted to do a quick promotion for the Executive War College, the event that the Dark Intelligent Group hosts each year, and an event that will have several of our speakers, including both Mick and John, at this year. It's a great event for clinical lab leaders and pathology leaders, a chance to network and succeed with those folks, and meet representatives from some of the nation's most innovative labs as they share how they add value to improve patient outcomes while encouraging health insurers to pay for this value. It's an event we've attended for many, many years and are happy to continue to support. And if you're interested in attending, you can use the registration code LIGHT150 to receive a $150 discount on your registration. Just going to send a quick offer for anybody who wants to open that screen and maybe go ahead and register after the event. You can open that page now and have that code ready to go. Sorry, that was the wrong offer that went off there. Let me get the correct one. There you go.
And if you are going to be there, make sure you let us know. We're going to be attending Lighthouse Valuebased. We'll all be there, and we'd love to meet up with you in person for a cup of coffee or a meal. So please reach out if you're going.
Absolutely. And then just a little bit about us here at Lighthouse here before we get started. With nearly 20 years of experience, Lighthouse Lab Services has become the nation's leading and most trusted end-to-end full-service medical laboratory consulting firm and recruiting. Whether you're looking to start up a lab or looking to grow your current business, we offer labs a way to accelerate their success. So for those of you who've joined us before, that's nothing new, but we'll have several options to contact us throughout this. And if you're interested in speaking more with our team about any of the issues discussed on today's call, we'd be happy to follow up with you. And then just a few housekeeping items real quick. This webinar is going to be recorded, so no need to ask for a copy of the slides or recording. that will be automatically sent out to everyone who registered after the event. We do have a Q&A function available, and we'll be answering a few questions here at the end as time allows. So feel free to drop those questions in the Q&A, and we'll review them and answer them at the end if we have time. And with that being said, we're going to go ahead and get started with our panel here today. All right, gentlemen, I think first and foremost, what's on everybody's mind as we start talking about the transitioning to a post-COVID, success and transitioning out of this public health emergency is, how that's going to impact COVID test reimbursement. And first and foremost, the public health emergency is slated to end on April 16th. There's a lot of questions with how that will interact with the recent decision to not replenish the HRSA uninsured fund that supports testing for uninsured patients. So I think what we want to start with here today is, several healthcare groups have asked for advance notice prior to the expiration of the PHE. Nick, I want to start with you. Do you expect we're going to get this notice with it being less than a month out? And if not, how is that going to impact testing?
Well, it's an interesting space we're in right now, because as of 12 o'clock last night, the HRSA portal's out of money. And yet, according to the CARES Act, you have to treat these patients, uninsured patients, until the end of the PHE. So we're in kind of this little bubble area where I think labs are going to do the testing and they're going to bill for it, and there'll probably be some retroactive payments. Now, will the PHE go forward, and will there be a notice? Boy, it would seem like the American Hospital Association and the AMA would push that and have that agenda there and make that happen. I would think that there will be some notice, and that there will be some political benefit for it to go forward a little bit more. Maybe one more 90-day thing just to give everyone a last hurrah. John, what do you think?
Yeah, I don't know if I have anything to add on the billing side. I think, Mick, you're the voice of authority there, but I think it does have implications, and there's a lot of questions also on the operational side for labs, right? As this endemic happens, what happens to these FDA, EUA approved assays that maybe didn't go through a clinical validation? What happens to labs that are processing samples from California and New York on these temporary waivers? What happens to personnel that are doing testing in the laboratory underneath waivers that normally wouldn't be qualified to do so? I think if you're a laboratory, now's the time you need to start buttoning those up. I don't think you want to be at the mercy of a quick cutoff for those, and you need to start planning to be compliant in a post-pandemic operational standpoint. I do think HRSA ending reimbursement was very sudden. Whether there will be, another tranche of funding, maybe. I think there's definitely some people being pretty vocal and trying to secure that, but certainly no guarantees at this point. And as Mick mentioned, as of yesterday, the funds are out. And so labs have a decision to make on how they proceed. I've seen labs sending notices to customers saying they're not going to accept samples that are under HRSA, but there's some gray there in terms of what a lab's rights are to be able to do that. So it's certainly complicated. I don't know if, Robert, if you have anything to add.
Well, I think you two have covered it pretty well. The interesting dynamic will be as the number of cases have fallen, as the Omicron variant has washed through. The last numbers I saw, approximately 280 to 290 million Americans out of 330 million have either been fully vaccinated and or have been positive for COVID. So there's a lot of immunity. And so that's an interesting political question on April 16th, whether the federal government would want to fund payment under HRSA through an extra funding bucket. And knowing the current Congress, that may just happen. But we'll have to wait and see. After all, it is an election year, so your folks in Washington would like to be reelected, and they don't want to disappoint the labs that have stepped to the table during COVID and done huge volumes of COVID-19 testing.
And I mean, another thing to think about too, and not be too doomsday about it, is the HRSA is supposed to be there to cover non-insured patient populations, that should make up less than 10% of total population of the US, and shouldn't be a majority of the testing that labs are doing. I do have some concerns when I see the amount of HRSA testing that labs are doing regarding whether labs are actually vetting those patients to see if they have insurance. And that brings up some more risk, right? If they're not, what does that look like as we get to the end of this and there's a lot of auditing that starts to happen, and we start to look at whether labs are doing their due diligence to make sure that they should have been billing HRSA for some of this testing.
You're 100% right there, John. That's one of my fears, is that we've actually talked to labs who we know aren't doing the due diligence on the front end to make sure those patients don't have insurance, and they're billing it through HRSA to try to get it done. And if you go back to the beginning of all this, when it started, people were just trying to get testing done. So they would literally run through people that might have had insurance through the portal. Maybe they didn't get hit on an edit. There are going to be audits here. OIG's audit come out and said, hey, we're going to do this. So it'll be interesting to see what the clawbacks or takebacks are on this over the next 12 to 18 months, or if there's some type of dispensation for that, to say, hey, we understand you were doing your best. We're going to relieve any responsibility for those type of accidents that may have happened.
Excellent points, gentlemen. And I think another thing that's really on everyone's minds here is, under the public health emergency, while it remains in effect, currently, insurers are barred from passing along patient cost sharing obligations for COVID testing. Now, do we think that, if the health emergency receives another 90-day extension, are insurers going to continue to accept these rules while the government's saying that there's no funds left for, reimbursing for uninsured testing? Or will we start to see a shift in the way that private payers are responding to COVID testing and cost sharing obligations?
Well, I think we've already seen some shift already, because some insurances have come out and said, listen, we're not paying for asymptomatic testing, that kind of stuff. And I think these insurance companies got to make a 5% profit every year. And they will look at their bottom line and their shareholders and come to a way that works best for them, which will probably be a way to deny these claims.
Yeah, I think we're seeing more reliance on at-home testing and rapid tests. And I think that naturally patients are picking up the cost for that. And it almost gets to a point where they're not bothered. They're going to Walgreens and they're picking up a test because their kids got symptoms, and they're just doing it, and they're not bothering to try to put that through. So I think there's a lot of cost sharing off the books that's probably happening right now, and that will continue. Whether, if there is another surge, which that's another thing to talk about here, is we're starting to see some trend lines in Europe and Asia that certainly look like there's some a surge happening there. Whether that'll carry over to the US, it looks like the Asia numbers are related more to Omicron, where the European numbers maybe are not, and we've typically trailed them. How we solve that? People are talking about antigen and rapid tests being the solution for that. I think that one of the issues that comes up is if you're talking about going back to school, employment testing, even travel testing, a rapid test is just so easy to falsify or divert. Like you're going to need some source of truth beyond the patient to say whether they're in a status where they should be around other people. And PCR testing has been that, and that typically has to be done in the laboratory. So it'll be interesting to see how it plays out for sure.
And then, Robert, I wanted to double back with you real quick. I know Mick and John both touched a little bit on some of the auditing that's been coming down, especially what might come down from HRSA in response to labs that have submitted a large amount of uninsured claims. But, just from the dark reports perspective and being on top of, recent news, have you started to see the OIG crack down on major instances of fraud and abuse related to COVID testing, or have we not quite seen that crush yet?
Well, that's an interesting question, because there have been federal prosecutions for fraud and abuse in COVID testing. And if you go back to the spring of 2020, the earliest months of COVID, there were some federal indictments announced, and that has been true over the last 24 months. when you dig into the cases that are getting the headlines as something recently filed by the Department of Justice, what's interesting is there is a COVID charge included, but it appears that these are labs that were doing maybe pain management and toxicology testing or even genetic testing fraud. And the federal prosecutors had been building a case for a couple of years. And then as these labs jumped on the COVID testing bandwagon, using the same fraudulent practices like violations of the anti-kickback statute because they were paying illegal inducements to the physicians, that COVID charge got added into the indictment. Now, there's an interesting case in Chicago. I don't remember the name of the lab, but in the last 6 weeks, a large COVID testing lab, which didn't exist before COVID and apparently has taken $200 to $300 million worth of federal money, has come up on the state attorney's radar screen in Illinois and 4 or 5 other states. And what brought it up on the radar screen was the fact that patients were not getting results. And in some cases, the results were inaccurate because they had problems, symptoms, and went to another doctor, got another test. So I suspect that the prosecution of lab fraud that's really based on those labs that have been doing COVID testing since the March 2020 period is going to trail out here over the next 24 to 36 months. It's just how long that takes the Department of Justice to put together a case and actually get it in the courts.
One area that I think...
I'm sorry. Go ahead, John.
I would expect that we'll see some auditing of some of the coding that was used, right? So under COVID, you got paid more if you were running tests on a high throughput device platform. Almost an honor system there. I don't know that I've seen much outside verification of that or, need to do it. And so using that code, I'm curious to see if there will be pushback and more documentation required to prove that. Also on turnaround time, kind of the dates that were used for making sure that you fell in that turnaround time window to be reimbursed. Some of those, I think that we'll see audit committees formed that go after labs. Maybe it's those labs like the one in Chicago that start to come on the radar due to failure to report samples or whatever. But there's a lot of tools in those auditors' bag now to go after. There's a bunch of strings they can pull at, and I'm curious to see what the outcome of that is.
And Mick, real quick before we're moving on here, what can labs and pathology groups be doing to prepare for some of these audits?
Well, the best thing you could do is go back and look at maybe the first 2 months of your billing and do an audit to say, did we bill anybody with insurance by accident through this portal? Did we violate any of these rules? The 48-hour rule, and you have to get the test done within 48 hours. You get a high throughput test, you get extra $25. Take 100 of those claims and audit them. Find out. Do some work on it. Because that way, even if you do get audited and you do find it, maybe you self-report, and that looks a lot better than tucking this stuff in a desk drawer and waiting for someone to knock on your door. That we do auditing across the board from charge capture all the way to collection agencies to make sure things are done right. And the people that hold their hand up and say, I did it wrong, help me fix it, are much more likely to be seen in a better light.
Great points. I'm moving on here to talk a little bit about some permanent changes that may last, post-pandemic, post-public health emergency here. John, I want to start with you. How has COVID changed the clinical lab business, and will that change persist post-pandemic?
Sure. I think it accelerated a lot of technology change in particular. I think it put pressure on where the bottlenecks were from a bureaucracy standpoint. So we saw regulations be kind of thrown out or relaxed. It would be nice to see if some of that stays where it makes sense, right? So prior to COVID, having a telemedicine physician order for a lab test was dicey in a lot of states, not recognized. And I think that we've seen wide adoption, and we've seen that it's been really beneficial for our country to be able to have people get laboratory testing through telemedicine, especially if they're not mobile, they need it quickly. It gives greater access, right? So access has been increased, which I hope that will persist post-pandemic. I think labs have also learned a lot of new tricks and tools, right? So we saw laboratories having more of a direct relationship with the patient. We saw pop-ups and drive-throughs and things that we had never seen before for testing. We saw QR codes being used to register patients. We saw text messaging for results of tests. A lot of cool things happened during the pandemic. A lot of terrible things happened. But in terms of our industry's advancement, I hope that we don't return back to normal and take all these things that we learned and just shelve them. And I hope we find ways to incorporate them into laboratory testing in an ongoing way.
Robert or Mick, anything you'd like to add on that?
I'll just stick with the fact that things that are seen cannot be unseen. So, and John, you had some great points about telemedicine and QR codes and drive-through. So what we've done is we set a precedent. So when this happens again, we have a template. It'll be easier if something else comes up in the next 3 years to go back and look at this and say, what did we do right and what did we do wrong?
And I think we showed as an industry that we're able to ramp up to meet demand, and that now we know what that playbook looks like. And so as other pandemics and things happen, hopefully they don't ever, but if there's a need for heavy lab testing, I think we have more of a playbook now than we ever did on how to get there and quickly meet those needs. And so I hope that we don't forget those lessons that we learned also.
Yep, and Mick was right on target. I would suggest there's two, what should we say, themes that are coming out of the COVID pandemic. The first one's going to be most interesting. In response to the pandemic and the lockdown, both federal and states relaxed many prohibitions on the practice of medicine across state lines. This is significant for pathologists. And so there's speculation that you've let the genie out of the bottle regulatory-wise, you can't put it back in, and that both the federal and the state establishment are going to have to keep the telemedicine, telehealth liberalizations in place going forward. So that's one thing to watch, because once the emergency is declared over, then they have a different regulatory environment to address if telemedicine has become so popular. Now, on the telemedicine piece, the CMS just released a study, and the use of telehealth services by Medicare beneficiaries increased 61 times from something like 40 or 50,000 uses, say in the year 2019, to something like 600,000 uses in 2021. That's powerful statistical evidence that many, many patients are getting comfortable with visiting their primary care provider in a virtual way. And then we can add to that the millennial generation and Gen Z, which are now coming out of college. They're clearly a generation that does everything over their smartphone virtually, and they're going to want to access healthcare services virtually. The other piece that's relevant for labs, so number one is where does the patient get healthcare service delivered? Is it virtually? Is it going into an office? Is it going into a primary care clinic and a retail pharmacy around the corner from where they live or work? That's another trend that we'll be talking about at the Executive Work College next month. The other bit is testing, and both Mick and John have touched on this. You have a large number of Americans now that are perfectly comfortable with going down to the pharmacy, buying the COVID kit, going home and running the rapid test at home, or collecting the specimen and putting it in the container and sending it off to the lab. And once again, the genie out of the bottle metaphor is appropriate here. There are a number of lab companies set up specifically to do consumer self-directed testing, or the direct-to-consumer DDC model. So I would assert to you all, a large proportion of consumers are increasingly comfortable with ordering their own lab tests and observing the results and acting upon them independently relative to whether they contact their doctor or not.
Great points, Robert.
Yes.
I think we touched a lot on there about how the relationship between providers and patients is changing, but I'm interested to hear your thoughts on how the relationship between labs, payers, and providers has evolved. Are there any permanent changes in the way that payers have responded to this pandemic that you think will persist moving forward? Nick, let's start with you.
No, there are no permanent changes. Payers, it's not like insurance came out and said, "Hey, you know what? It's a pandemic. We're going to help you out here." No, these are businesses trying to make money. So, I would say no. Maybe there's some changes from Medicare and Medicaid and those type of things. The HRSA program and those type of things. But fundamentally, labs are still going to struggle with payers. Pathology groups are still going to struggle to get in contracts if they need them. That game is not getting any easier. That's my 2 cents worth.
John or Robert, anything you'd like to add on that?
Yeah, I don't know if the payers have changed, but they've probably been watching and seeing that people are very open to doing laboratory testing. I think that as we start to shift towards more of a value-based care system, payers are going to be invested in looking at how to stratify patients, and if patients that are not coming in for testing, I know older males typically fall into that category, are open now to, if they ship a box to their house, they might do a test, and that's able to give a payer some data that helps them early detect a costly incident before it happens. I think you might start to see that. Like, the proof of concept has been established that people are open to telemedicine and lab testing. If you can do a telemedicine visit cheaper, I would think payers are probably watching that too, right? If it costs less for them to do that than to have someone come into an office, then they're going to be interested. But I don't think we've seen the changes yet, but I think we have some proof of concept for a few different things that may be beneficial.
Yes, and so if you look at relationship between laboratories and payers and providers, a couple of things to watch for the labs is I'm going to call them an integrated insurance plan arrangement. Medicare Advantage is a good example of this. Medicare Advantage, CMS will pay the health plan X $1,000 per Medicare beneficiary in that market, like Houston or Chicago or Milwaukee. And then it's up to the insurance plan to arrange a fixed payment to the hospital for inpatient services and the physician who's quarterbacking the outpatient outreach care. Well, in those settings, the provider and the payer are on a fixed reimbursement per year. And so they have every incentive to do early diagnosis and active intervention. And this is an opportunity for lab to have a relationship that supports the doctor and the payer. Risk management is something I'd suggest all of you lab folks understand in the Medicare Advantage program in particular. Essentially, it's a concept that if Robert is a healthy Medicare senior, maybe the plan pays $10,000 to Humana, and Humana's paying X $1,000 per year to the doctor to keep me healthy. If I have an ICD-10 code diagnosis of chronic kidney disease or adult diabetes or cardiovascular issues, there's a risk adjustment on that premium, both to Humana, and then Humana passes that down to the doctor. The point here is it's the lab test that's going to help the doctor get a verified ICD-10 code that the doctor and the payer can use to get a risk adjustment premium for Medicare. This is moving into the private payer segment as well. And John tipped something in his comments before this, which is people doing lab testing at home. I'm starting to unfold this one, but Tricor Laboratories in Albuquerque actually has a program in place now where they're sending a request for test and a test kit out to selected patients who in their database indicate that they may be at risk, say as an undiagnosed adult diabetic. And I believe that what it is, it's a finger stick on the paper card that comes back in for something like hemoglobin A1C. There's a case of a lab being proactive at helping a physician group manage their population so that they can do an early diagnosis and confirm it in order to get a higher reimbursement. So that's all an opportunity for every one of your labs to identify how you can help the providers and the payers in your regions do an early detection, a more accurate diagnosis, and then active management of the patients.
Yeah, I think the thing that's going to be valuable in a value-based care system is going to be heavily reliant upon data, and laboratories produce more data than any other part of healthcare, right? And so I think that that's our currency as a lab is we produce the data. We know how to identify risk. We know how to stratify patients. And the more that we can demonstrate that value and find ways to interact with patients and figure out who's at risk and flag those for treatment, I think is going to be good. I do know of some commercial payers that have engaged a direct-to-consumer group to send out tests to their patient populations that they feel are at risk, and they're seeing better adoption and more likely that the patient responds to those programs than it's when they typically had done a request, hey, you need to go into your doctor's office. They see less people being compliant with that than returning a lab test. That's an at-home test.
And then just to quickly close out this slide, John, I wanted to direct this one to you. What moves should a lab that made a significant portion of their revenue from COVID be thinking about now when we talk about the pivot?
Yeah, if it's from a scientific standpoint, I think the answer is if you have a PCR instrument that can be revalidated, you want to start thinking about that revalidation, right? So that's going to look like putting in a panel that maybe is testing for UTI or sexually transmitted diseases or respiratory panels or wound and women's health. All of those types of tests can be done on the equipment that a lot of COVID testing was being performed on and be performed by the same scientists with that same skill set. So I think that's the low-hanging fruit, easiest pivot. The question there is the patients that were sending you COVID tests, what's the best fit? Are any of those panels a good fit for that? If you were doing school testing, for a school system, trying to offer a UTI panel, probably not going to be a really easy pivot there, right? But figuring out how to utilize the equipment and the staff that you already have in a new way. But I also think that trying to take some of the lessons you learned about how you deliver that is really important, and marketing directly to patients. I think that the patient relationship is going to be the most important thing, and that puts you at the head of the table. The laboratory has struggled for a very long time to get a seat at the table, and typically has held their hand out for their 2.5% or 3% of healthcare spend that they get paid to do their portion. And I think the more that the laboratory can establish relationships with patients and then utilize things like a telemedicine doctor for diagnosis or for prescribing, now the laboratory is at the head of the table, controlling those funds that are coming in and is paying, a few percentage points to those physicians for the role that they're playing. That's not going to be at scale, going to change healthcare anytime super quickly, but that is a way for laboratories to start to pivot and start to think of how could I market my laboratory services directly to patients that might be interested.
Well, great response. I think in the interest of time, we're going to go ahead and move forward to talking about some shifts on the horizon here. We've got about 20 minutes left in the discussion, although I don't think we'll use all of that time to allow for a couple questions here at the end. But Robert, I wanted to start with you. When we talk about shifts on the horizon, are there any other large market-changing shifts that labs and pathology practices should be looking ahead towards in the next 3 to 5 years?
Definitely, and John cued one of those, which is data. labs are rich in data, and some of you may be familiar with the concept of Clinical Lab 2.0, which basically says that a lab, in order to prosper in coming years, needs to know how to create clinically actionable intelligence out of the lab test results it generates. And so in this model, Clinical Lab 1.0 is the transactional lab. It gets paid fee for service. Higher volume equals lower average cost per tests and a greater margin on a fee for service reimbursement. Clinical Lab 2.0 needs a Lab 1.0 foundation because it's the data that's generated by the lab tests that Clinical Lab 2.0 incorporates with other patient data sets in order to allow the lab to deliver value both to payers as well as the providers, and patients who are doing their own testing get involved in this as well. And so the key is there's two good windows of opportunity for COVID labs, for example, that want to pivot, which is how can you help labs in your service area identify undiagnosed patients that have chronic diseases. That has great value to a physician because the physicians are scored on statistical performance, and it has great value to the payers. And then the other piece is care gaps. Are there diabetic patients in a doctor's practice who have not had their hemoglobin A1C test in 12 months? Those kinds of care gaps. So that's a market change over the next year. If you're going to proactive care, labs need to help the doctors and the care teams identify who's at risk.
Yeah, I would say I've seen labs successfully do this. Whenever reimbursement is rich on a lab test, you see laboratories get very creative, maybe not for the most altruistic reasons, to figure out how to identify patients. And when we've seen it, I think it's been met with mostly like a repulsive response so far. I don't know that. I think the approach still has some value, and don't want to throw the baby out with the bathwater, but I would say cardiac testing is a good example of this, right? Cardiac panels started to reimburse at around $8,000 a piece. And if you had a hereditary history, 2 people in your family or so that had cancer, you would qualify, and you could get paid for running a inherited disease, cardiac or cancer test on those patients. And when that started to happen, you saw laboratories get really creative and start marketing directly to patients. They would start with call centers that were calling on seniors, asking them questions, trying to identify who had those risk factors, connecting those patients that were at risk with physicians that could then go through the symptoms with them and order these genetic tests if the medical necessity was there. And they did that very successfully, so successfully that they stopped allowing it, right? Like that, the government didn't like it at all. PGX had a similar history. I think that it still allows for a good blueprint, if better controlled, to say if we were to try to attack, say, chronic kidney disease and incentivize laboratories by putting a common sense but lucrative enough reimbursement on the test, they would solve the problem. They'd go find those patients that have those symptoms and be able to get them to test and identify those. And I think that would save our health system money on the long term by getting to patients early. But I don't know that there's broad acceptance of an approach where the laboratory is soliciting patients. We do see that in pharmaceutical, right? Where pharmaceuticals will put commercials on TV all the time looking for patients that have those symptoms. Can we get there with lab? Maybe. It'd be interesting.
That's a great point, John. Why don't we see a lab Super Bowl commercial saying, "Hey, if you have these side effects or these symptoms or this history, talk to your physician about getting this lab test ordered because this might show that your A1C is high and prevent you from having adult onset diabetes."
Mick, you're missing those Cologuard commercials on TV.
No, I'm ignoring them.
No, there's a few cases of it, but I don't think we've seen widespread adoption of that yet. And I do think that I'll say again, when the lab has a relationship with the patient, it's a whole different dynamic in terms of how they're paid and the seat at the table that they have. And so I really like that model if it can be done not as a money grab, but with common sense. I think that would really help to lift the lab. I think that there's probably no time in history that the lab's been better suited to make a pivot like that. Most people know the name of a few labs now. They probably didn't know some of these smaller labs besides LabCorp Quest prior to the pandemic. Now they know their local regional laboratories. And there's an opportunity for those labs to maybe start to establish a relationship with those patients and offer more services. And I think this is probably the time, if any, for a lab to make that move.
Alex, you want to go into the next question?
I think we might have.
Yeah,
lost.
Alex might have froze up on us. That's okay. It happens. Let's talk about lab testing growth. John and Robert, what do you guys see? A quick 3-minute synopsis from each one of you on where do you see lab testing growth? I see the benchmark of COVID testing coming down to reach a certain level, and then we got to go forward from there. And John, you mentioned a little bit of it. Robert, I'd like to hear your 2 cents worth too.
John, you go first.
Sure. Yeah, I think the areas that will naturally grow are going to be PCR-based infectious disease panels. I think that you have a lot of labs with the capability to do this. I don't know how much bigger the pie got compared to pre-COVID, but I think the awareness is certainly going to be raised. You're going to have teams of laboratory sales reps educating physicians on the value of these tests. I do think these molecular tests are better tests, right? So where they're going to gain market share is probably from microbiology. So typically we'd seen these tests. If you were going to get a UTI test done, you would have a culture or plate sensitivity that would occur that takes incubation periods of a couple of days. During that time, physicians are guessing at antibiotics to try to throw at the issue. Bad for antibiotic stewardship, not great for the patient. When you can replace that with a molecular test that can result out in hours, I think we'll see better healthcare outcomes. I think we'll see better antibiotic stewardship. You can run an antibiotic resistance panel with that test. So I think that we'll see a lot of growth there. I don't know if it's going to be enough growth to keep everybody fed, right? I think there's going to probably still be a thinning of the herd. There's just a lot more players going after that same market. So that's the easiest pivot in terms of technically what a COVID lab would need to do to be able to perform a new line of testing. Maybe is still a challenging pivot from a Salesforce standpoint on how to acquire customers.
I would concur with John that there's going to be a lot more PCR testing, and that's going to be driven by the fact that there's a lot more PCR instruments out in the marketplace, and people have an economic motive to repurpose them. Infectious disease testing is obviously one place for that. If you look more broadly at the world of diagnostic testing, genetic testing, and in particular whole genome sequencing, is going to be a fast-growing area. This is consistent with the move towards precision medicine, which is the desire of healthcare policymakers, the employers who pay for insurance, as well as the payors and the physicians, to really be able to detect chronic disease conditions much earlier in the curve when they can prevent somebody who's, say, pre-diabetic from becoming diabetic. That's going to be an opportunity for labs. And with whole genome sequencing, they're cracking the DNA of the human genome at an incredible rate. And the cost of doing genome sequencing in local, say, community hospital labs is becoming feasible. So there's a company out there in Nashville called Concert Genetics, and they have a spider that crawls 300 or 400 lab websites daily looking for genetic tests. This will surprise many of you. Concert Genetics says there's 65,000 genetic tests being offered somewhere in the United States at the current time. And that's a challenge for physicians to understand what the tests do. There's also the question of, are all these genetic tests actually have clinical utility, i.e., does the answer allow the doctor to get a better outcome with the patient? And many of those tests don't have that kind of clinical documentation to support it. But going forward, a lot more testing for infectious disease that's PCR-based, and a lot more genetic tests, particularly that may have an underlying whole human genome.
I agree completely on that. I think also genetic testing related to some liquid biopsy testing, or using some of that equipment to do liquid biopsy testing, is going to be a big growth area for the lab industry. I think being able to identify cancers early in a very non-invasive way may become eventually part of the standard screening or treatment of care, where you go in because you're 40 years old and they're going to take a tube of blood and they're going to check you for lung cancer, colorectal cancer, bladder cancer, prostate cancer, all of those things. We see some companies have come out with some pretty good sized panels there. That just seems like a win for everybody, right? When you can have a less invasive test that finds expensive health conditions that, sometimes are often fatal very early in the process when they're more easily treated, and it saves the insurance company a lot of money because, say, bladder cancer, for instance, one of the more expensive cancers to test, but if you can catch it early, you can have some really, really good outcomes there. So I think these liquid biopsy tests will be a really big growth area for the lab industry.
Hey, I just want to throw something out. This is a little shout out to Julie. We were talking about drug ads on TV, and Miss Julie noted that labs don't have profit margins to buy Super Bowl ads. So
that's true, but do labs not have profit margins because they don't buy Super Bowl ads, right?
And that goes to my final point, is that we've created a ton of labs in the last 2 years, and John, you mentioned something about there's going to be excess capacity, and I think what we're going to see is if we had 25,000 new labs last year developed, they're not all going to survive. Some are going to have great sales and marketing, and they're going to go out and grab some market share, and they're going to be able to survive. But right now we have all these labs vying for a fixed number of tests. So the winners will be the ones who win in the client's mind and in the provider's mind. The question we should ask ourselves is, what's this look like in 3 to 5 years? What happens to these 25,000 extra labs? Is there going to be a fire sale? Is there going to be a market out there for PCR equipment, used PCR equipment? So, I mean, who knows? Maybe we'll have, COVID, 25, and we'll have to start this thing back up again. But, it's like the question here is the next step for businesses for labs. Businesses have to be aggressive. They have to be like, living organisms. They have to go out and find food, and they have to make sure they're good at it, or they won't survive.
I agree. And I think as we move into value-based care, I don't still see a clear path where you're going to be reimbursed for the test that you're running on like a risk share necessarily. I think there'll always be a fee for service component of that. I think who pays you that fee may change, where it may shift to labs being paid by, say, a physician group that has, or a health system that has responsibility for that life. If that happens, what's going to be important to them? How will they select their lab? Is it going to be strictly cost? If so, it's going to be hard for small labs to compete against a LabCorp Quest with the economies of scale they have to be able to be very efficient in the way that they run lab testing. Or is it going to be service and couriers and the speed that you're able to get a result and the customizability of a panel, or the some of those parts? And we've seen LabCorp and Quest have long delays on a lot of lines of testing, and small independent labs have won based on turnaround time. And so that might be the case, right? So as we have a bunch of these labs, are they able to compete and win business locally by having relationships with those physicians, providing more of a concierge service, exactly what those physicians want, and providing good quality service and a quick turnaround time might be how they win business from the big boys.
Good point.
All right. Well, thank you, gentlemen. I think we pushed a little further than we expected to with the time, but I do want to just address one question really quick. The first one that came in, since we promised we'd be taking them. From Brenda Cox, Does the panel believe that at-home flu testing will evolve like COVID testing, or is the moment where that may have happened already passed?
I think absolutely that it'll be available. Patients will have, if you wanted to get an at-home flu test through telemedicine, I believe you already can do that. I believe you'll continue to be able to do that. Whether the patient mindset has changed to the point where that's how a majority of people will order it, I'm not sure. I doubt it. I think it's probably still a minority, but it makes a lot of sense, right? That if you think you have the flu going into a setting where you're going to be around a lot of other individuals, maybe people that are compromised or immunocompromised, isn't great for us as the whole population. So if people could get flu testing at home that's accurate and reliable, I think that's a great answer. And I think that it will be available, just be a matter of changing habits.
Yeah, and I think we're training people. You know, we took a year and a half and trained people not to go to the ER, not to do anything. And you know, the pathologists are seeing the downward side of that with the number of stage 4 cancers. But we've trained people not to do this. And so if we can train them to say, hey, telemedicine your doc, I have these symptoms. Yeah, we'll ship you a test. Boom, it's done. That's the next step.
And I think flu in particular is so seasonal that it really lends itself to some at-home testing or telemedicine where you can ramp up and very quickly. Brick and mortar doesn't grow and shrink quickly, right? And so it's hard to meet that need through a brick and mortar boots on the ground solution. But I think it's much more efficiently met through an at-home telemedicine type solution.
Great, thanks, guys. And in the interest of time, we're going to go ahead and wrap up here and give folks just a few minutes of their lunch hour back. Almost took the full hour there. But if we didn't get a chance to address your questions, and I know it was a very wide-ranging conversation, please don't hesitate to reach out to us at the email address listed there. The slide-out offer that went up while John was speaking was also a contact form with the availability to reach out to us. So, you know, any questions or concerns you have, please follow up with our team. I just wanted to remind everyone one more time about War College. You know, thank you again to Robert for joining us today and sharing his great insight. We can't say enough good things about War College and hope that everyone who's on the call today at least, you know, considers attending the event.
Yeah, this is just a small teaser of the stuff that you see there. There's so many good sessions this year. We're looking forward to being in person and seeing customers and clients and meeting new people. And we hope other people will come out. Robert, I think you mentioned that we're on pace for a banner year of attendance there. Last I heard.
That's a good thing.
Well, yes. In fact, that's a good point for everyone. It seems like concern about COVID in live conferences has gone away. We did a smaller executive work college in San Antonio, Texas, November 1st and 2nd. We planned on 300 attendees. 400 folks showed up. We had screening with temperature checks and a rapid test available for those whose screening didn't match requirements. We didn't have to do one test on 400 people 3 days in a row. So this is an interesting comment to all of you that life is coming back to normal. And I know some of you have institutions with travel bans, et cetera, but we'll have COVID screening protocols in place at the Executive Work College, April 27th and 28th in New Orleans. And there's lots of sessions on how to repurpose COVID testing capacity and lots of sessions on how to get paid for your COVID tests as well as your genetic tests. So many things that Mick and John and I have talked about today will be addressed in depth, and we'll give it back to our most talented moderator.
Oh, thank you, Robert. Just one final note for everyone. Next month, we will be doing another webinar on April 13th, adjusting to changes for COVID test reimbursement. If you would like to sign up for that now, you are welcome to do so with that slide out offer right there. And we'll be going a lot more in depth on some of the topics touched on here today, the end of the HRSA uninsured program, how that interacts with the potential end of the public health emergency on April 16th. And then I saw quite a few questions too about LCDs and some different coverage determinations for infectious disease we'll be touching on that as well. So going to be a lot of great reimbursement information, and I hope you can join us for that one. Just want to say thanks again to our panel today, Mick, John, Robert. Excellent discussion. Thank you, guys.
Thanks, Alex. Thanks, Robert.
you.
Thanks, Mick.
Appreciate it.
Thank you all.
Bye, everyone.